So welcome everyone to a webinar brought to you by Cecelia Health on the topic of submitting claims for diabetes and nutrition coaching and remote psychosocial monitoring and treatment of management services. For those of you who don't know, Cecelia Health is a leading technology-enabled expert clinical and digital health coaching solution that positively transforms the lives of people living with diabetes and other chronic diseases. Hospital and university specialty diabetes clinics have recently utilized Cecelia Health to support the needs of their staff and patients that have been exacerbated by the COVID-19 pandemic. Our experience in providing telehealth and remote coaching services for the past 10 years to major health plans, providers, and other customers has really given us the right background and experience on billing codes. And it's an evolving area as demand for telehealth has really skyrocketed recently, and both providers and health plans are trying their best to figure out what the right codes are to use for various services. We have a really great panel of healthcare experts today to really help us break down this complex topic. We have Dr. Arnold Saperstein joining us today. He is the Chief Medical Officer at Cecelia Health, and he has over 25 years of experience in healthcare, both as a physician as well as an executive, having been in charge of Metro Plus Health Plan as president and CEO. He's also been working very closely with the specialty diabetes clinics this year to oversee the execution of the programs and to provide guidance on the billing process. Also from Cecelia Health, we have Belinda Matthews joining us. She's a clinical director, senior clinical director at Cecelia Health, and she's a certified diabetes care and education specialist and a registered dietitian. And she's been playing a really key role for us in building and managing our diabetes coaching programs. And she's also been working very closely with the specialty diabetes clinics, including Hackensack Meridian Health, to ensure the best possible outcomes for both physicians and patients. Finally, we're honored to have a really excellent team joining us from Hackensack Meridian Health. We have Dr. Javier Eisenberg, Dr. Jenna Klein, Krista Orr, and a few of the other folks from their team who will help us try to navigate the complexities of the billing codes and also talk about their experience working with Cecelia Health. So on that note, I will pass things along to Dr. Saperstein, who will take us through the billing codes. Dr. Saperstein, the floor is yours.
Thanks so much, Vic. Good afternoon, good morning to people who are on wherever time zone you're in. I'm hoping over the next few minutes to share, some of the codes that can be used for managing patients on a remote basis, on a virtual basis, that we've been working with the clinics on, and also opportunities for any practices to be able to learn the billing codes to utilize both the physician codes as well as other staff and clinical staff that are in the practices, so that there can be reimbursement for care management services for their patients. Just want to share that most of the codes are based on my own research, and that we've been working with the clinics to see that we've been able to put this in practice and be able to work with both CMS, Medicaid, and with various health plans to be able to understand that these codes are valid and working with them, and to be able to build those codes. There's a little bit of background. On November 15th, a year ago, 2019, just about a year ago, the CMS released their 2020 schedule, and in it, they revised two major coding schemes on for care management. One is they created the remote physiologic monitoring codes and clarified those, and I'm going to go through in detail as what those mean. And they also created a whole new structure for single chronic conditions, which is principal care management. So I'm going to go through those three categories, but just before I go on, mention that the CARES Act was passed in relation to COVID, was signed into law on March 27th. And the big change in the CARES Act is that CMS allowed for telehealth and remote care services beyond the direct patient services, which allows for patients to get care on a virtual basis rather than in person. Next slide. So just to quickly review what I had just said, there are three major categories for care management. One is remote physiologic monitoring. The second is both non-complex and complex care management, and that's for individuals with multiple chronic diseases. And the new coding scheme for principal care management, which is for individuals with one major chronic disease. And as I mentioned before, this was created by CMS, but has been adopted by many states in their Medicaid billing schemes and also by many private payers. Go on to the next slide. And this is more as a background, because a clinical staff physician is very clear, but there's a QHP is a mnemonic that's written down in many of the codes. And I just wanted to explain what it is. So QHP means either the physician or other qualified staff that are by training have a specific scope of practice, and those includes both the physician, nurse practitioner, physician assistants, certified nurse specialists, but at this point does not include dietitians or RNs. The clinical staff that's mentioned in most of the codes, and I'm going to point that out as I go through the codes, means individuals that are not, that can be beyond the scope, that are clinical employees within the practice or remotely clinical employees through the practice. Next slide, please. So what RPM is the ability to manage individuals remotely at a distance. So we take, and diabetes counts as one of the, as an example, for remote physiologic monitoring, and that's having an individual has a CGM at home, which is a continuous glucose monitor. And remotely, we can help the individual understand, to understand their technology, to upload that technology, and have a provider review it at a distant location. So it's a remote monitoring where the patient has the device at home, and the a provider is able to review it at a remote location. And there are different codes where the provider can get reimbursed for both the patient education as well as the clinical staff to help individuals learn how to use their technology. Let's jump ahead 2 slides into the actual codes. Great, thanks. So the first slide is the codes for what a provider can bill. So there are a few codes. And starting in the middle is a 99453. That's the initial setup. That's where a physician or a qualified healthcare professional orders the equipment, teaches the person how to use it, and does the initial setup. 99091, which is the code to the left, is where it's the interpretation. It's where the provider's office reviews the results and makes clinical determinations based on the results they reviewed. And if you notice here, as I said, this is provider staff, so this is only providers or other qualified healthcare professionals, which can be a PA or a nurse practitioner, but not the otherwise clinical staff. And the 99454 is device supply, where the provider's office is utilizing their time to supply materials and devices to individuals for monitoring. But the next slide goes more into detail of what can be billed remotely or by entities that are not specifically the physician staff. So those are 99457, 99458. The only difference between the two is the 99457 is the first 20 minutes of time that can be billed for time spent in helping an individual do the monitoring, and the 99458 are additional times in 20-minute blocks, and each of these can be billed once every calendar month. But what's very important here, as you see in the definition, is it's remote physiologic monitoring treatment management services that can be provided by clinical staff or the physician or otherwise QHCPs. So you can utilize RNs and dietitians and other staff to actually help the individual understand their monitoring and help them on a month-by-month basis to both understand the data, upload the data, and allow the provider access to the data. So these are codes that can be used by any clinical staff. And another very important point here is, if you look at the last bullet, it says it's performed by physician, QHCP, or clinical staff under general supervision. What general supervision means, the provider doesn't have to be in the same location. The provider can be in their office, and the clinical staff can be at a remote location, and the patient can be at a remote location. So they're generally supervising it. It's not a direct supervision. Most of these codes don't require direct supervision. They require general supervision. Let's go on to the care management codes. Next slide. So just to define a little bit what the next category is, those are the non-complex and complex care management. And the definition appears, on the next couple slides again and again, but the understanding of what these are individuals that have multiple chronic diseases. And there are two possible categories of care management, one of where it's non-complex, but you're helping individuals with their multiple chronic diseases, another where it requires more complexity. But the goal of the care management is to help individuals create a care plan, to help them coordinate their services with other physicians, other professionals, other agencies. And you're also helping the individual understand, both the individual or potentially a caregiver, to understand the disease, understand how to manage the disease, understand their self-management that's required, which is a lot of what we actually do now at Cecelia Health. And the codes, like I mentioned, geared to physicians, but can be billed by a physician or a qualified provider. And I'm going to talk about two groups of codes. We might as well, for the sake of time, jump right into the codes in the next two slides. Let's go one slide forward. Great. So the first category, both these two slides are talking about individuals that have multiple chronic diseases. This slide is for individuals where there's care management that needs to happen. And the care, which talks about care plans, helping individuals understand the disease. And this slide is for non-complex care management. And in a few seconds, I'll get to the next slide, which talks about the complex codes. And there are the initial and the follow-up. So the 99490, which is on the left side, is care management of at least 20 minutes of clinical time directed by the physician or qualified healthcare professional. And this can be billed also once a month for the 20 minutes time, and assumes approximately at least 15 minutes by the billing practitioner being spent to educate the individual. Then when we get to 2058, that's for additional time. So if you notice here, I've highlighted the words clinical staff. So the physician does the initial training in care management, and then he or she uses the clinical staff, which can be staff such as we have at Cecelia Health or other staff that are in the office that are directed by the physician. And if you notice again, it says general supervision. So the 99490, the physician starts, and the 2058, the G2058, are done by additional clinical staff to actually provide additional education to individuals in managing their diseases. We go one more slide to the complexity. And there I just to point out that this one is for complex care management that requires significantly more time, where there's a lot more complexity to the diseases, and these pay a little bit higher rates, but it requires a more complex intervention. And the first one, the 99487, which is the physician-guided coding, can actually last up to 60 minutes. But then additional time for each additional 30 minutes is an add-on code of 99489, whereby the provider has their clinical staff. And again, I've highlighted in the second bullet that the physician starts the care management through the 99487, and then can utilize non-physician clinical staff that are directed under general supervision. And this is the last category, which is, because we talked about complex and non-complex, where it's multiple chronic diseases. And here, these are codes that can be used for individuals with just one chronic disease. So the other ones would have needed multiple diseases. This one, you can have just diabetes as a primary diagnosis. And there are two codes here, the 2064, 2065. So as again, the 2064 is the physician or nurse practitioner or physician assistant. It's the qualified healthcare professional that are starting out the care management of at least 30 minutes, billed once a month. And if you notice on the bottom, it's not clinical staff, it's the physician at QHCP. But if you have other staff doing care management for this one single disease, that's G2065. Those are individuals that are clinical staff time. That can be other staff, such as dietitians, RNs that are in the practice to help the individual do their single disease care management, and that can be billed as 2065. And if you notice, the rates are very different. I haven't been pointing out the rates. I put it there more just, to give a sense where when the physician's involved, it pays $92 for that 30 minutes, and when the RN and other ancillary staff are involved, it's $39.70. That's just the local average CMS rate for facility non-facilities, and it's the same with all of the codes. And when we share the deck, that there are also nutrition codes specific to registered dietitians, and that's 97802, 97803, and those are 15-minute. They're billed in 15-minute intervals for intervention by a registered dietitian. And the difference between the two codes is 97802 is the initial visit, and 97803 are the follow-up visits to provide the nutritional counseling. Thanks.
Thank you very much, Dr. Saperstein. Now we move on to talk a little bit about the work that we've done with Hackensack Meridian Health. So I'll ask members of that team to go off mute and talk a little bit about what's the experience been like since COVID-19 and how that's changed some of the elements around telehealth and the reimbursement specifically.
Thank you, Vic. Can you hear me okay?
Yes, we can.
Hi, it's Dr. Jenna Klein. I'm here with multiple people from our team here in pediatric endocrinology at Hackensack University Medical Center, Joseph and Cesare Children's Hospital. Quickly, we have our chief, Javier Eisenberg, one of our nurse CDEs, Donna Appelgren, nurse manager, Krista Orr, our operations manager, Renee Brady, and our Director of Operations, Tom Anton. So thank you for joining. And thank you for the opportunity. And before I forget, I also wanted to just thank the engagement with Cecelia has been wonderful. And I wanted to thank the Helmsley Foundation for making that possible during COVID for our patients. From what I will get from Donna, I think Cecelia, Belinda, and Belinda's folks engaged over 150 of our patients during a 90-day time period where we'll talk a little bit more about the experience. But in general, we're a group, we have 500 to 600 patients with diabetes. We see patients up till age 22 in general, and start transitioning them to the adult services after age 18. We're moving that to age 20. Most of our population across the country, but mostly here, 95% type 1, with a growing type 2 diabetes population. I'd say that close to 3/4, even more, are on technology. Many of them are on, most are on sensors, even when they're on multiple daily injections. Our network, and I think we do have some of our brothers and sisters from the South, our network boasts 2 pediatric hospitals with subspecialists 60 miles apart. So we're located about 5 miles west of the George Washington Bridge. So we have a cohort of patients from New Jersey and from Rockland County, just to give an idea. And in pediatrics, the effects of COVID were, thank goodness for our children, more indirect on kids' health. So kids have been mainly spared from the illness severity, but our hospital workflows have really had to drastically shift in order to handle the cancellation of non-essential visits in person, and the fact that our general pediatricians in the area have really been the frontline folks to prevent our kids from coming to the hospital. In pediatrics also, because I know we have adult folks on the call as well, diabetes is mostly tackled by the pediatric endocrinologist space, not the primary care physician, where in type 2 diabetes, which is most of diabetes in the country and in the world, the internal medicine folks will handle those and therefore be the stewards of those codes that Arnie was talking about, Dr. Saperstein was talking about. So folks have to understand from my learning about this, and I'm trying to be as self-taught as Dr. Saperstein is that, when for the older folks under Medicare and the adult population, these chronic care management codes the time frame will time will be shared, and the ability to code has to be shared with the primary care doc and not just with the specialist. So I think that's an important consideration just to mention. So what we had to do, we were actually very well positioned to shift to telehealth, as we had even prepared prior to COVID in January and February to purchase workstations and do remote patient visits to better engage our teenage college-bound kids. Little did they know that they would all be stuck in home. So it actually was, I don't want to say a silver lining when so many people have lost their lives, but it really added a little bit of a leverage, I guess, to push our already desired platform to reality. And then along with the public health emergency and the care acts that were discussed, we were able to start billing for our own doctor visits and provider visits with these patients over telehealth. The chronic management, the buckets that we have to sort of consider, the way I sort of set these aside, is to consider, internally, if our practice and within the network wants to use the PCM and CCM codes and documentation and all the things that will have to entail. And we're working and partnering with Cecelia in order to try to make that a reality. So that will include, electronic health record, template, billing coordination, and compliance in order to see if we can move towards that and if it would be lucrative for us and better for our patient care as we move towards incentive-based reimbursement as opposed to fee-for-service. The second bucket is, where are we going with the public health emergency, and the telehealth ability to bill. So we have to always think about that. And then the third part is, being able to continue to engage Cecelia to combine these two considerations for the CDs to be able to, from Cecelia to be able to bill like our salaried CDEs. And that's the next consideration. So we had I wanted to bring up Donna, if possible, to give a couple of success stories, if that's okay, on this engagement, because this is really the crux of the benefits of working with Cecelia.
Great.
Thanks, Donna.
Thank you. Okay, so I do want to talk about several of our patients in specific, but also in general, just the benefit for our visits to be done remotely. Having technology available to be seen at the visits is obviously key when we're not, and a lot of our family members have previously never been able to download from home, for instance, their pumps, or even connect their Dexcom to the cloud so that we could see their data. So, I mean, I have one patient in particular who has benefited greatly. A1C is generally greater than 14%. I don't think we've ever had her A1C greater than less than 14%. We finally, with the help of Cecelia, we got her a Dexcom, and then we were able to actually share that data. And it's hard to even explain how difficult that actually was, but that was tremendous to even get that information for the first time, in the 4 years that she's been coming here. So then we recently actually were able to get her on an insulin pump that integrated with a Dexcom. And because of those interventions, for the first time ever, her A1C was actually 10%, which maybe is obviously not a goal, but for her was a tremendous success. And obviously, and the family has become more engaged also since starting with this technology. So that happens to be my patient. I have another patient who had a similar experience, not as poorly controlled, but we have never even been able to download their pump for whatever reason in our office. And Cecelia CDE met with them for many episodes, and they went to a library to help them download there. So again, for the first time ever, we were able to see some data on that patient, and that family was so very, very grateful for that help. Also, so I mean, and then we have another family who's been very reluctant to have any sort of technology, and she doesn't even, she learned for the first time to download her meter. Unfortunately, we didn't get to the point where the mother would apply the Dexcom sensor that they have, but at least we were able to see her data remotely, having this mom download. So another patient also, we were able to get on the Dexcom and see the blood sugars, and the parents gave such high praise to the interventions and the patients of the Cecelia CDE. So, and that is, yes, and a lot of our patients, unfortunately, they didn't ultimately connect, but that was not at all the fault of Cecelia, because sometimes I think we had like 17 tries or something to try to touch base with the family, and even with our help, they just didn't connect. But those are just a handful of the success stories, but it really made a huge difference in our ability to conduct a productive telehealth visit, to have that technology for at our most at-risk families.
Thanks, Donna. I think that's a very good point that I neglected to say, but you just touched upon, and this is Dr. Klein again. At peak, we were up to probably about 75% of our usual volume that combines our diabetes and endocrine, and pretty much got in close to all of our diabetes patients to connect with us via telehealth. But the preparation that is required, as you all probably know if you've done this, to get a productive visit, as Donna said, requires really requires a lot of back and forth prior to the visit, which speaks to the chronic disease management codes, because of all the connections and time that we could sort of add up over time to be able to be used. But just nitty gritty, if we don't even think about billing right now, just the time that Cecelia was able to put in, given their flexibility, was very much appreciated by both the patients and us as the I guess I'll say in-person care team, even though it was remote, to have that information in our charts in media and available on the various cloud-based systems at the time of the visit. So I wanted to touch upon that. The other things that we decided at the time, and the benefit of Cecelia, was, those 17 calls with the patients at their suggested best time to reach them sometimes never really amounted to anything. So even I don't want to say failures, as we were saying, no fault of theirs, but even those that didn't necessarily work as expected, demonstrated to us as a team that maybe we should shift our attention and our focus from patients who might have various social determinants of health that are not going to ever make them able to do the download and get things ready for a productive visit. We may be able to shift those resources to others who may be able to benefit. So we did choose 4 at-risk populations for Cecelia to focus on and referred to them: new onset patients, patients who were teenagers transitioning to adult care, those who were chronically at hemoglobin A1C levels above 10, and then the PrEP group, so people who needed help preparing for their visit. And we had great effects by separating them into those buckets. I think we were able to demonstrate where we were going to be able to continue to engage Cecelia that would benefit our practice. I think some of the challenges will still be, if the private payers will be able to give us anything if we want to bill with Cecelia as our extenders, and making sure that patients are aware, which is another thing that I just want to supplement Dr. Saperstein's talk about, is that patients will get will be responsible for visits, for their copays, et cetera, if they exist. So that has to be sort of agreed upon, and our network compliance folks want to make sure that people are aware that these are billable services.
Well, thank you so much, Dr. Klein and Donna, for sharing that information and those stories. Really appreciate that.
Thank you.
So I'll pass things along to Belinda from Cecelia Health, who can talk a little bit about the results and outcomes of the work that we've been doing with Hackensack Health and also with some of the other clinics across the country.
Great, thank you, Vic. So, Dr. Klein and Donna mentioned a couple of ways that we worked with their clinic in particular, and really looking at how we supported patients was pretty much anything and everything where the support was needed. This is a time, where there was so much unknown as to what could be done in clinic, and so really just been able to step in and virtually through telehealth support patients in any way that they need to with their diabetes. And so what I thought would be helpful is just to share some of the top patient barriers that were addressed by the Cecelia Health CDCESS team. And so maybe it's no surprise to anyone, but technology was definitely a challenge for a lot of patients. And this, really was an area where we could take some time to support patients uploading or downloading their devices, as well as making sure that they were prepared and able to and ready to connect to their provider visit. So that would be something else, another area when it comes to the technology side that was really important to make sure they could ultimately connect with their provider. And then psychosocial support, we know that there's been so much over the last couple of months that has been very challenging, and being an ear to listen to someone, really just listening and being able to provide encouragement, give them a little bit of peace of mind and answer questions that they have that they might not be able to as easily get answered. Trying to call the clinic, trying to get in to see someone, as telehealth was a great way to be able to meet with those patients and support them. So those were the two main barriers. And then you can also see other areas we supported patients was, those who had a lack of support, lack of understanding of their device, any financial barriers related to diabetes supplies, as well as some patients with learning limitations, and then lack of understanding of nutrition. So this was another area we could support patients. When we look at the next slide, it talks about really the topics that were discussed the most. And, probably again, no surprise here, and just based on some of the things that Donna and Dr. Klein shared, pump download instructions and CGM download instructions were a big part of how we supported patients. One thing to note here, and I'm extremely passionate about data and being able to empower patients with data to better manage their diabetes. And so not only did we support patients by helping them download, but also then taking some time to provide education around that, showing them some reports and providing them some tips, or really just pointing them to areas maybe to look at on the report, because we know data can be super overwhelming. And so trying to help a patient understand where they could potentially focus when it comes to them downloading at other times. I think the other thing with downloading is, our goal was to help a lot of these patients get connected so that they could have the data for their clinic appointment. But one of the things we talked about with so many of the providers, Dr. Klein, Dr. Eisenberg, was not, just this is not a one and done. This is kind of the future, and being able to support patients through telehealth and have their data is super important. So again, another area, just it's not a one and done. This is continuous, and providing patients with that skill to be able to continually download their data and get support from educators or from physicians. Other topics that were kind of higher on the list were really reviewing hypoglycemia, how to handle and treat that, nutrition and how that fits into their daily life with diabetes, CGM troubleshooting, meter support, and then your psychosocial support again. So those were some of the top discussions and topics that we focused on with patients. What I thought would be helpful to share now is really just some results from a 12-week pilot study that was conducted by the Jaeb Center for Health Research, along with Cecelia Health, and this was funded by the Helmsley Charitable Trust. And this really just shows success with remote CGM initiation and usage, along with coaching. So what you can see here are some of the results. So 1.3 point reduction, 1.3 point reduction in A1C across all participants, 11% average improved time in range, 94% of participants use CGM at least 6 days per week, and 2.7 average increase in hours per day spent in range. So what this really shows is these outcomes demonstrate, that this can be a really huge cost saving for health plans, as well as it shows the ability to successfully initiate and support a patient on CGM. Something to note here, as these patients were trained through telehealth, so virtually, they were supported, data was reviewed, all virtually. And so I think this is really important to show that supporting patients and providing education through telehealth can still be extremely effective and valuable to show these outcomes and help patients continue to do better in managing their diabetes. So yeah, Vic, back to you, I should say.
Thanks a lot, Belinda. I appreciate the update. So in terms of next steps, I wanted to get Dr. Saperstein to help cover the next slide for us. And then we will get to the Q&A. I've already got a few questions, so please keep those coming, and we'll definitely dedicate some time, in a few minutes to answer those questions.
So I think to tie it all together is like, where are we going from here based on what we've researched and what we've done? So Cecelia Health historically, for many years, has received our revenue to take care of patients like directly from health plans, where we get a list of patients, we do the interventions, and it's paid by health plans. But over the past year, thanks to the generous funding from the Helmsley Charitable Trust, we were able to provide this work that was described by the individuals from Hackensack and also by Belinda, and what we learned from that, and to work directly with the practices. The challenge there is, once the grant funding was winding down, so many of the practices realized the tremendous value of having access to these remote virtual support services that we were able to provide, both from the CGM perspective, the training, the education of the patients, the preparation for the visits. So the question is, can it be sustained financially by the practices billing for those services? So what we've created for the next steps to talk about is, we're going to be looking to do a pilot, first with Hackensack, maybe potentially with other providers, where we will provide the services to the patients. And since they won't be funded directly through a grant, the providers will be billing for our services through the codes that I shared with you earlier in this presentation. And we're going to look to try to prove the model that through the validity of those codes, that practices can have remote services provided and be able to bill and sustain those programs on a financial basis. And the ultimate goal is, the patient shouldn't be getting, we want to make sure that the payers, both the private payers, Medicare, Medicaid, will pay, so the patient shouldn't get bills for the services. And then by having, as was described, those combined services of ours together with the direct provision of care by the providers, should improve patient outcomes and improve patient satisfaction. So, and another major issue that we can also address is, there are many practices where the patients live very, very far away from their endocrinologists and their doctors they see, and being able to receive services wherever they are on a remote basis makes it so much easier for them to get the comprehensive care that they need. So we're looking forward in the near future to be able to have a part 2 of this webinar, and to be able to share the results that we found in those pilots and billing for those claims being billed for the services we provide. And just one of the reasons we're at this point is, over the last few months, I've been in touch with practices all over the country who all say they're at a similar point, that they are looking at potential claims, but really have not had the experience, because it's new to be able to have remote delivery of services. So we're hoping to be at the forefront of learning the best ways of putting everything we talked about into full practice, and to be sharing with all of you the results of that pilot and that study over the next few months. So thank you all for participating.
Thank you very much, Dr. Saperstein. So I will open it up for Q&A, and the first question comes in from Amy. The RPMs need an order and consent signed by the patient, and is that for a year? They have to see the physician first to get that consent and order before coding a 99457 and a 99458 through a registered nurse. Can consent be verbal, or must it be on paper? So, question really about consent, it sounds like.
I wonder if my understanding is, of course, the provider needs to order the remote patient, the diagnostic tools, and a consent needs to be for this. We get verbal consent when we begin initiating care with the patient, but I think maybe the team from Hackensack might have more insight into this also.
We were talking about this as well with compliance. Our group of compliance folks sort of, I would say, trying to say this sensitively, cover all of our bases. So we were talking about getting a written consent regarding some of the, using some of these codes, and more of like an expectation given the newness. But I don't know if it's written that it needs to be written, but we were discussing having it written, so that there's no, it's clear. The expectations are clear.
Great, thank you. Hopefully, Amy, that answers your question. The next question comes from Zach. Can you please comment on the uptake of private insurers allowing the various codes that were discussed? So I guess, a question around, are these codes being accepted by the various insurers?
So I think that's really what we just talked about in that next step slide, is that when I've tried to reach out to practices about put this in practice, many of these care management codes and RPM codes are new, and the ability to actually provide so much of these services virtually are new. So CMS definitely has approved it. In documentation, I've seen that many state Medicaid programs have also accepted it. I found it on some major insurers' websites, like United Healthcare has a list of specific remote codes that can be delivered, and they actually have tools that are available. But about most of the private insurers, I think what needs to be done are pilots. We need to work with multiple practices. We can provide these services virtually, and and test out the model by reaching out to the main insurers for each practice and ensuring that they understand the value of these codes, that these codes are valid from CMS, and that they can be put in place. So I think the short answer of all of that is we don't know for sure right now, but it's something that most private insurers should eventually include, and maybe through the impetus of sharing some of our results and what we've accomplished, there's an opportunity to actually have those private insurers who haven't yet add those codes.
That's great, thank you, and thank you, Zach, for the question. One question that came in earlier on, and actually went back to that slide to clarify. It says here the code 97802 is for face-to-face visits. I assume this also includes virtual visits in 15-minute increments, correct?
Yes, the face-to-face through a video at all. It's right. It's with these new codes, I think, as my understanding is, they can be billed on a virtual basis, because most of what we do now is direct communication also through video.
Right. So an interesting question here from Taryn. Can programs like these replace on-site CDs and RDs and potentially reduce clinic overhead? So I guess that's more of a question for the team at Hackensack.
So sorry, can you just repeat the question?
Oh, sorry. The question was, can programs like these replace on-site CDs and RDs and potentially reduce clinic overhead?
Donna's still on the call, so I don't want to say we're replacing her.
I think the way I'm reading this is more of an augmentation.
Augmentation, supplementation. Yeah, that's what we're looking to potentially continue to do, barring COVID, we're assuming that vaccine's going to work and we're going to be able to get through this. So, we have to speak on different levels, as I was discussing with the different considerations that we have to go through when we're talking about this. But I see a cooperation. So I think that the benefits are that, we would not have to worry about vacation days and schedules and things like that, because Cecelia's cohort of educators and support people would be supporting each other. So there's always a Cecelia, just like the namesake. So everyone would have a Cecelia available. They can also, there's more flexibility with time. And then obviously we're still going to be seeing patients in person, and they wouldn't be able to substitute for that unless we had videos in each room. So I think there are creative ways to merge, but given the fact that we know that these monitoring devices are so wonderful, but do require a lot of work to get people on and using them, and the learning curve is so steep. Having Cecelia to augment the practice is the work. It is basically the model that we want to do. But I mean, I think if you're considering, we'd have to look at the the apples and oranges and the checks and balances. But if you're considering hiring two live CDEs versus, I think it's a consideration that you'd have to think about, just based on what your practice needs.
And also to add to that, as we'll be doing a pilot with Hackensack, if there are other practices that are interested in a short-term pilot, maybe over December and January, we could work with other practices, and you can test out the model of working with us and having our staff work with your patients on a remote basis, and see, test out both the financial structure and also hopefully see the really positive clinical results that we've been able to obtain with the other groups that we've worked with so far.
The other part of it is that, our nurses do work with other patient populations, not just our patients with diabetes. So Donna in particular works with our Obesity Healthy Futures program, and she loves our patients with diabetes. She loves our patients who are in the Healthy Futures program. But as the Healthy Futures program expands, there's opportunity for Donna potentially to slide into more of that space. And then we would need to fill that in with other CDEs, potentially Cecelia, et cetera. So it opens up opportunity for our nurse CDEs, nutritionists, et cetera, to do other things that could extend the physicians, one, two, bring more joy to their everyday job, and fulfill what they want to be and do.
Yeah, thank you for the answer, and I think definitely more access to physicians and clinicians across the board, I think is beneficial to the patient population. So one of the questions that came in from Lydia is around annual wellness visits. Is it done under general or direct supervision of a physician? And if diabetes is discussed during the annual visit, does that qualify for the same coding or different coding, or any of the coding that we discussed?
I would think Hackensack knows this better, but the annual wellness visit is more of a physician-billed visit rather than a support visit.
Yeah, I think that speaks to what I was saying a bit originally in that, and that's one of the problems with us being pediatric endocrinologists, is that in general, diabetes is handled by us as the specialists, whereas the annual well visit, if you're the primary adult provider and you're handling diabetes, that's going to fall up into the chronic care management codes. So you wouldn't be able to double dip with the endocrinologist if that patient also sees the endocrinologist, is my understanding. Again, they're new for us to explore, but that's something that compliance kept beating me with. No, I'm just kidding. Well,
so Lydia actually just chimed in with a clarification. So, as if if the annual health visits are now considered are now done under telehealth because of COVID, is it added as a billable code under CMS?
It's a good question. I know that I think this is separate then from the telehealth, the remote patient monitoring, but just from my own recollection, the annual health assessment for adults, I believe, was something that you could do via telehealth. In kids, their wellness exams was not. So not knowing what age patients you take care of, I remember that being an issue, that our general pediatricians were not able to just bill the same way as for the annual visit checklist things that the adults were able to bill for via telehealth.
Right.
Regardless of whether they were diabetes patients or something else.
Right. And Dr. Eisenberg, are you off mute now? I noticed that you were having some issues with your mic.
Yeah, yes. I was
Dr. Eisenberg is just trying to get the new PlayStation, so he's using. I think that's where Dr. Saperstein was having issues with his connectivity. He was trying to refresh the new PlayStation.
So we have time for one more question, and so Barbara was asking, and this is probably a question for Belinda and Donna, in terms of addressing financial challenges that come up during these visits. What are the ways to deal with those questions? Because presumably that's not something that can be directly handled by the clinic.
Could you? I don't know how. Could you repeat the question in terms?
The question was around how do CDCESS address or assist with patient financial challenges or questions around financial, like getting medical supplies and access to medication.
Yes.
Yeah. All right. So yes, working obviously closely with insurances and which is a big part of it, and we do have a large Medicaid population. I would say, Dr. Klein, you could probably back me up on this, but I think at least 50% of our diabetes patients have Medicaid. So, working within the confines of what they require. In terms of,
and some uninsured patients. We've had some patients who transferred from international locations, refugees, et cetera, who were on either charity care or very limited self-pay. So we do send resources assisting them and rely on some some of the donations from Helmsley, actually, beyond Cecelia, to assist. But they do have at least the patients that we've worked with do have the technology of the phones to set up so that they could at least use their screens on their phones in order to have the visit with us. Those specific patients I'm thinking of.
Vic, and I would just add, I think when it comes to supplies or, medications, a lot of the pharma companies, so a lot of that we could talk about options that they might be, manufacturers might have, different saving cards, different patient assistance programs. A lot of the device might have payment plans. I know that doesn't always apply to the supplies, but those are things that we can provide as resources to patients as well, when it comes to challenges in that area.
Well, I just wanted to also say that, and Belinda will remember, as well Donna, we had some patients with some language barriers, and Cecelia is always great getting a translator if need be, but they also have on staff folks who spoke some of these languages, and I'm not talking about the Spanish, French, and the most common, and that really, really helped some of our patients get better engaged. And we realized that some of the barriers where they might have, thought to be financial weren't necessarily only financial, but language was a key, and they were able to speak in their own language and were able to sort of really dissect what the barriers were a little bit better. I think I can think of at least 3 or 4 patients, Belinda.
Yeah, someone Malayalam, I think that's how you say it. That was one of the languages we had. One of our educators spoke that, and just being able to connect in your own language can make a big difference for really truly understanding, and communicating those challenges for sure.
Well, thank you very much. I know we're over time, and I appreciate all of our presenters staying on a little late to answer all the questions, and for all the attendees who were able to join us and to ask all those insightful questions. We will be sending out a recording of this webinar to anyone who registered in the coming days, and we thank you very much to everyone who presented and attended.
Thank you.
Great, thank you.
Thank you.
Thanks.